Lovely welcome to you all to this session in relation to problem sensing. And I've got two most amazing colleagues who are going to be talking with me and together, and we're just going to have this most brilliant conversation, which we've already started, by the way, prior to even coming onto the screen. So the session is titled, Can We Be More Problem Sensing? And our speakers are going to be Sam, who's going to come in first, and Maxine's going to come in second. What I'm going to do is give you very briefly their biographies now. Then I'm going to give you a little bit of an overview about what do we mean by problem sensing, because you're probably all sitting there thinking, I think I know what she's talking about. And then we're going to get into a conversation. Sam's going to give her reflections first. Maxine's going to give some reflections, and then we'll chat amongst ourselves. So after I've given you my overview of problem sensing, Sam is going to talk, and Sam started her work in the NHS in 1996 and has a background in operational management and leadership of mental health services and health and social care commissioning. She became Chief Executive of Sussex Partnership NHS Foundation Trust in March 2017, and I've known her ever since then, and she's an astonishing colleague and a real person of inspiration, and so it's an absolute delight to have her here. She's a Chartered Manager and a Companion of the Chartered Management Institute, Chair of the Health and Care Women Leaders Network, and delivered by the NHS Confederation, and a Leadership Fellow at St George's House, Windsor Castle, and a member of the King's Fund General Advisory Council. So after Sam, you'll hear from Maxine, Maxine and I have worked on and off together at numerous occasions over the years. She's currently the Executive Director of Quality, Innovation and Improvement at the West Ambulance NHS Trust. She's an Honorary Professor of Improvement Science with the Manchester Academic Health Science Centre, and served as a Health Foundation Governor for 4 years until 2014. She's an improvement leader with over 30 years experience of leading improvement in the NHS. So let's have a little think about problem sensing. I think very much it's crucial that we understand what this is, given the last year that we've had, because generally dramatic changes, such as things like the pandemic, require extraordinary adaptive responses. And we know that our staff, our organisations, our teams, our departments have had to become extraordinarily adaptive. And so good things have happened as a result of that, and not so good things have happened as a result of that. And people are being put in situations where things are uncertain, they have little experience of, and to be frank, have been really quite fearful and anxious about what they've been doing and how they've been doing it. So problem sensing is the act of noticing this and interpreting this. So data being quantitative and qualitative, and constructing meaning out of all of that data about the changes in the context, the behaviour, the culture, the conditions in the organisation, which then help you take the right actions, help you then adapt and adjust as well. And so it is the necessary precondition. It's basically, in its simplest form, gathering as much data as you can in order to understand how to adapt and adjust, rather than simply just adapting and adjusting on the hoof. And it is, to some extent, if you're interested in the whole world of safety and safety 1 and safety 2, a way in which you can look at safety 2 in its ideology as a form of problem sensing. You ask yourself in safety 2, how is the system functioning? How are people adapting and adjusting? How are they making things work? And why do they fail when they normally go okay? So you need to notice what and how people adapt. You also need the right culture, which isn't to punish people when they adapt and adjust, which unfortunately can happen if they're going against policies and procedures and then they're doing something different. And you need to notice the warning signs when people are drifting into risky situations or behaviours that you aren't happy with. So that's a kind of general sense of problem sensing. And so I'm now going to ask Sam to give some sense of what problem sensing has meant to her over the last year, but in a way, kind of how has your year been? So over to Sam.
Thanks, Suzette, and it's great to be here with you this afternoon, and all of those who have joined us online as well. And good to be here with Maxine. And these are great opportunities, aren't they, to share and learn from each other. So what I'm going to share certainly is one perspective amongst many. And I think being really curious about this is probably a great place to start. We're all still learning, and I'm absolutely in the thick of that learning too. I suppose there's sort of three points I want to make, but before I get into that, there's something for me about complexity and complexity theory. Whilst it's been quite some time since I've studied complexity theory, when I think about healthcare and I think about the NHS, you think we're the 5th largest organisation in the world. We've got 1.4 million staff, paid staff. We've got a temporary workforce. We've got volunteers, and we have patients who aren't just recipients of care, but they're self-managing their care as well. So nothing, I think, more complex, actually. And we sometimes do ourselves a disservice in the NHS when we sometimes get frustrated when we wonder why things haven't gone as well as they've gone, or where we perhaps take learning from other sectors and try and sort of retrofit it into the service. This isn't a supermarket. We have multiple different supply chains, some of them predictable, some of them incredibly unpredictable. And if you just look at the kind of the discourse of a day in the health service, I think the King's Fund 10 years ago said there were about 1 million interactions. More recently, they said that's probably about 1.5 million. And that's what we count. There's lots of things we don't measure, we don't understand, we don't particularly look at. And there's, of course, the significant discretionary effort that everybody linked in with the service is doing day in and day out. So it is complex. And when you look at sort of complexity theory, the sort of the 4 main kind of planks of that, whether it's chaos theory, network theory, systems, or adaptive, I do think we are both a sort of a system, but an adaptive system. We're a bit like the Great Barrier Reef, really, a sort of an ecosystem. So the people, the structures and the processes and the environment in which we are operating are all connected. And from a problem sensing perspective, we need to be horizon scanning and looking at all of those. We're also an organisation that has quite a centralist view. And so with a centralist view, you sort of get structures and hierarchy that comes with it. And I suppose my sort of 3 reflections really over this last period has been, as a leader, we've had to adapt our leadership styles. We've had to really become problem solvers. We've also had to look beyond the structures that we would usually rely upon, the voices that would usually support decision making, to solve and adapt rapidly over the past sort of 15 months really in terms of COVID. So it's not as simple as just being a decision maker. You have to be the sort of the problem solver. And to do that, to your point, Suzette, for me, there are sort of a series of questions you're constantly asking yourself and being curious about. Where are we? What are we seeing? What's the data telling us? And as you said, it's got to be both quantitative and qualitative. And with the qualitative data, where are you listening? And I do think even we're learning some of the lessons through regulation of the need to listen far more to our patients, and in a real-time way, not a sort of a retrospective way. But as part of that, you've got to have good relationships, you've got to have trust, because I think particularly when you're problem sensing, are people telling you as the leader what's really happening? Are you getting the full picture? So you've got to have your antennae up there. And in doing so, you've got to be kind and compassionate. So if I think about my career in the health service and experience and observations over the years, and I think this is at the root of speaking up, really. How do you truly encourage speaking up when actually cultures don't always support the person speaking up? So hierarchies can be helpful around control and clarity at times, but they can also stifle problem sensing. So how do you create that cultural environment? So My second point is about control. Okay, so on the one hand, through this pandemic, we've had the longest running major incident. It has been command and control. Actually, there's been a lot of positives about that in many instances, and even in my own organisation, people really welcome the clarity and the pragmatic decision making. But one of my observations as we go through a sort of transition over the months ahead now with the introduction of integrated care systems, as organisations maybe restore some of the governance that they had, or indeed hopefully adapt their governance structures, how do you maintain the sort of the good bits really of enabling a more flattened hierarchy and embracing? I think one of the things we've seen has been clinicians coming far more to the fore in decision making. So relinquishing control is really hard, and it's really hard. And the things that really test it are particularly safety issues and quality issues. What will be the first set of behaviours experienced when something doesn't go to plan? And how will you react? So again, further emphasising the importance from problem sensing with the structure, the people and the relationships. And then just finally, the third point I just want to pick up is around culture. You know, the sort of the conditions that are created to enable active problem sensing. And I think as a leader, you know, trust is at the heart of that. Do we trust people to know what is best to do for patients? Do we have the structures and able to support them within that? But actually, how do we embed some of the innovation? And one of the things that I think is really fascinating at the moment is a lot of the conversations around restoring face-to-face appointments. So that's something that's challenging every part of the sector. You know, we had probably 5 years of innovation in 2 or 3 months, but it was working at the height of the pandemic, keeping people safe. And actually, how do we adapt that and move that in a hybrid model now, whilst taking the learning with us and not simply just restoring what we had before? And I think that requires some courage and some bravery and a culture that accepts there may be some things we get wrong, but the gains would be greater. So my 3 points really would be, as a leader, how do you kind of really occupy that space of the problem sensor and solver? What does that mean for our leadership? Recognizing the structural reforms, relinquishing control being kind of really key. And I think particularly as we transition with integrated care systems and how we react as we move through that, both proactively in problem sensing, but how the system reacts when one thing maybe doesn't go well. And then as leaders, how do you create the culture and the conditions to enable this to flourish?
Gosh, there's so much richness to pull out of all of that. That's absolutely fantastic. Thank you so much, Sam. And just for the audience and the participants who are watching, please feel free to have a chat with each other or comment about anything that either Sam or Maxine are talking about, and then post your questions in the Q&A. That would be really lovely, and then we can post them. I've got tons of questions for them, but you know, I know that you need to have your chance as well. So thank you so much, Sam, for that initial kickoff. So Maxine, over to you for your 10 minutes. That would be really lovely.
Brilliant. Thank you, Suzette. I mean, how do you follow that then? That's quite a tough one, isn't it? I think you've packed a huge amount in there, Sam. So thank you for that. I will try to kind of tease out and maybe give a couple of specific examples. I think there's the one thing that the first point really that I'd like to make is, I think as boards and as senior leaders in the NHS, we all need to acknowledge that actually problem sensing isn't new. This is something that as a senior leader, we will have used, whether that's in healthcare or in another environment, to actually get ourselves to what I would class as kind of almost the leadership that's required for leading at scale. I think one of the things that we probably should also acknowledge, though, is that problem sensing will mean different things to different people. And Suzette, you gave a lovely, I think, succinct description of it. I think it's fair to say that it's kind of almost been an evolving phenomenon, though. So back in, I think, 1999, some of you will know the work of Don Berwick. He gave, I think, a very seminal speech at the annual National Forum on Quality Improvement called Escape Fire, which I think in its origins, it has the work of Carl Weick. He obviously, many of you will know, is a safety scientist who's looked at reliability in organisations, and in particular in high reliability organisations. And they describe something called sense making, which I think has lots of affinity with problem sensing. And when you look at the kind of the story, if any of you haven't actually seen Escape Fire, it's available in full actually on the internet, so you can get it off the Commonwealth Fund website. And it's a beautifully written, very eloquent narrative about how essentially healthcare needs an escape fire. It needs something, it needs to do things differently in order to survive. And in fact, you know, Berwick was talking about the healthcare system in the US in 1999, but it is remarkable how many analogies that narrative has to today's NHS, and particularly in the place we're in at the moment with COVID. And I just wanted to highlight really some of the clarity of definitions that they gave, which I think resonate with what Suzanne and Sam have both said, is that they said that there are 4 defining characteristics of sense making in organisations. The first one being improvisation. So the ability to be able to invent when the old formulas fail. And I think many of us have seen that we've had to do this both with our governance systems, but also with our operational delivery. So for us, for example, when at the height of the pandemic, we just didn't have enough ambulances to respond to the demand. So what do you do? And how do you sense make to actually problem solve and improvise? And interestingly, many of you will know that we were incredibly creative. You know, we brought patient transport services into patient emergency services. We worked with the military. We worked with fire and rescue. You know, there was this almost a community spirit of people coming together to improvise, where previously I think we'd seen almost invisible barriers that prevented us from doing that. So I think that was probably a common feature for us, was this constant requirement to improvise. I think the second one is a bit trickier to understand, but Weick describes these things called virtual role systems. So what he's describing is the function of a team, a social system, to assume that when the structures aren't externally apparent, we can make them work. So for us, for example, we're working with 3 integrated care systems where they all have their own social systems, and many of us work in partnerships where people have got their own social systems. And we had to quickly adapt to their emergent response and share information in a really agile way so that we could actually continue to grow and develop. And I think for me, that requirement from what we've learned is that, if you think you've communicated once, then communicate 10 times more, and then you may well have landed the information. And similarly, if you think you need to listen 10 times harder, and then you may have got the message. So it cuts both ways, really. The third thing you talked about, and I think it's really, really smart, this one, is an attitude of wisdom. So the ability to move forward without excessive confidence or excessive nervousness or cautiousness in the absence of fact. So none of us have ever managed a pandemic before. How could we know? How could we know what to do? And yet, as Sam described, we were constantly synthesizing information. We were drawing information, quantitative and qualitative, to take decisions that actually, often were key decisions about whether, services stood up or didn't. And when you don't know, you have to admit you don't know. I think people very quickly see through leaders who try to be overly confident, and they really appreciate leaders who are happy to say, we don't know, but you know what, this is the path we're going to take. And if we need to deviate, we will. And, you know, I think we've seen that writ large in our NHS organisations. And actually what we find is that rather than creating a sense of fear, that creates, I think, a stronger sense of assurance for people. Because actually they know we don't know. They absolutely do. They're all smart characters and they all know that. So I think the final thing is he talks about respectful interaction. So this I think really interestingly about truth, honesty and self-respect. And, you know, we do need, don't we, as leaders to be candid, as I've just described, but we also need to be compassionate and provide a clear and decisive narrative for people to follow, which doesn't feel like it's harming people when it lands. And that's quite a difficult trick to pull off, especially when you're in the heat of the moment. I think we're all consciously checking ourselves all the time about, not about what we're saying, but often about the way we say it. And just if you'll bear with me finally, Suzette, I come to the ambulance service having spent about 30 years in the NHS. And I've been in the ambulance service for 3 years. And when I came into the ambulance service, I think the phrase command and control had inherently in it this kind of, you know, people when they said it were kind of a little bit nervous, a bit cautious about saying it, like it was something that we shouldn't be doing. And I think that Sam mentioned it and said, you know, there are some really excellent things about command and control, which I think we've all learned through the pandemic. And actually, when you think about it, it feels like a bit of an oxymoron to be talking about command and control and sense making in the same sentence. But actually, I'm just going to describe something now. So in the last 3 years at the North West Ambulance Service, we've responded to countless serious incidents, so-called critical incidents, including, you know, significantly the Manchester Arena bombing. And just last week, so on Saturday evening, I was on call. And we had some of you will know, we had an explosion in Morecambe in Lancashire. And that made the national news. And I just wanted to kind of give you a little bit of a sense of what I think happened there. So our operating model in a crisis is exactly like we just described, command and control. So not necessarily something we would kind of fit with problem sensing, but bear with me. So within the hour of the incident that happened at 2:39 a.m. on Sunday morning, I, as the exec on call, was in receipt of a methane report. So a structured report from a gold commander on scene who was leading a response where we worked alongside Lancashire Fire and Rescue and Lancashire Police. So this is a team of people, 3 services working together to a common goal, who've never worked together in that setting before. We sent multiple resources to that incident. So we sent our hazardous area response team, who deal with extraction, 6 ambulances, an advanced paramedic, 4 doctors and 2 on-scene commanders to manage the response. So we treated 5 casualties at scene, 4 were taken to hospital, 2 with serious injuries and sadly a young child who died as a result of the incident. The major incident was stood down at 6 o'clock for us. It continues for fire and rescue. So all of that happened in a 4-hour period. And under the leadership of that gold commander, an incident command structure was rapidly established in line with the organisation's policies and protocols for us as a Category 1 emergency responder. As things escalate and de-escalate, the frequency of oversight meetings changes, and these were agreed through multi-agency strategic command cells, which were happening the whole time that event was happening. The purpose of the incident command structure, in my view, is problem sensing. They've got the oversight that's required to make decisions relating to patients and staff safety, clinical priorities, and to assess the scene and continuously adapt what they're doing. They were working with services outside of the emergency services, such as the electricity board, the gas board, to try to cut off supplies to the affected areas. And they were dealing with numerous displaced families in the middle of the night. So what happened? Well, briefing and debriefing occurred continuously. And I think if there's one thing for me that the pandemic made me realise, was that the tempo of our communications and our ability to brief and debrief is essential to vital oversight. So open channel radios facilitated rapid information exchange between the crews on scene. And I actually think Teams has opened the channels up for senior leaders so that we can interact in that way. So we don't have open channel radios, but we do now have this platform. And I think there's a lot to learn from this, some of which applies to our routine work, but I think much of which gets lost in the day-to-day. So I guess my conclusion is really that command and control isn't cruel and rigid, perhaps in the way that I'd thought it to be, but it is the epitome of wisdom deployed really, really well. And I think one of the things I would say in terms of leaders, our responsibility is to really understand how we can be more problem sensing and how we can use unexpected opportunities like the ones I've just described to you to really, really get people to understand problem sensing and surface this as a behaviour that's required in today's healthcare system, and really get people to understand that we can replicate this behaviour if we see it, we name it, and we reward people for doing it. So maybe next time we see healthcare teams in action, we don't just listen, we don't just watch, but we actually draw out our problem sensing examples and get our glasses firmly on so that we can see this real time. Thanks, Yvette. That's me done.
That's you done, is it? Right, okay. That's absolutely brilliant.
Yvette, why did I say Yvette? Who knows? Who knows? Suzette would have been much better. I apologise.
Oh, rubbish. Don't be silly. I'm only joking with you. No, I completely agree. I mean, I think prior to the pandemic, I would have said command and control is definitely not the way to go to engage people and get buy-in and all. And then you just totally get the fact that actually there's a need to hold people, to contain people, to create certain boundaries and to create a way in which people can feel safe in order to make decisions. So you're actually sort of shifting that command and control to help people make decisions, which is really fascinating. I totally have to get with you. Now, you've described also the on call at the weekend. You've described probably being up for many hours, and I imagine your year has been the same. And Sam, I imagine your year has been the same. And we talk a lot about well-being for staff, but actually, can we hone down on just even the two of you? The years you have had, how do we sustain all of that? And we don't really, do we? But what's your reflections on how you have been able to cope with the amount of the work it's been given, the amount of constant, unprecedented challenges that you've had to deal with, and yet still try to get through the day job as well, and do that in a way that supports all of your staff. But who's looking after you in terms of all this? So my heart of this is, I think problem sensing isn't just about the data of your functionality of your system. I think problem sensing is about knowing about you and how you're coping and about how your staff are coping. So it's intricately linked into well-being and all of those things. So I'll start with you, Sam, just to give a sense of, is this sustainable and how do you cope?
Great question, and good timing as well. I mean, it has been a year like no other. I think there's sort of a book in there somewhere, and everybody's experience has been different. It's been quite personal, given the impact on individuals, family and friends, and the whole circumstances everybody found themselves in. And there's no right or wrongs there. And I think, sharing stories and narratives around stories is powerful and helpful, because I don't think we've really unearthed that yet. And I think particularly with the dominant focus in the media, where there were quite rightly lots of focus around intensive care, lots of focus around the physical health impact. And as a chief executive in a mental health trust, I guess, one of the, we really leaned into the evidence around trauma that veterans had experienced. And, one of the things we know about that is it can be over a prolonged period, and it can come at different times to different people. So I think in a nutshell, the focus on wellbeing has been a really positive thing that we need to sustain now. As we move through the next few months. You hear me, I'm choking quietly here. I think I swallowed a fly or something. But what's a concern at the moment is the transition. So we are rapidly restoring business as usual, but not just business as usual, a very significant recovery programme, which is demanding, requires rapid action, and it's all about safety, isn't it, for our communities in terms of restoring healthcare services. We haven't quite come through, I think, the period where people have been able to fully recover, because I describe it as almost a reawakening. And just this week, obviously, with further restrictions lifting with lockdown, people's lives have changed quite fundamentally. And this is going to take a very significant period of adjustment. I think the emotional and physical impact on staff and our communities is very, very real, and it's very, very prevalent. And what we must seek to avoid to do whilst we're looking after people's well-being is not restore a lot of the things that are non-value adding, because quite simply, people have not got the bandwidth in order to do that. And we need to make sure we take the positives, flexible working being one of them, and really maximise that over the months ahead. But I think I don't have a conversation now talking to people saying it almost feels tougher now than it did in April, May, June last year and January this year. And that needs to be at the forefront of our minds, and we need to remain curious about it. And I think when it comes to leaders, our behaviours are really important. We know that they can really impact culture. So I think we need to make sure that we really utilise our support networks effectively during this. And I think the work that the NHS people team have done has been second to none. There is a plethora of support, but we need to make sure people are aware of it, and that they can also access it.
Brilliant. And very much looking after you, take a drink, please. This is a conversation where we're amongst friends, and we just, look after yourself even just while you're sharing. So Maxine, in the same question really, what's it been like for you in terms of that?
Yeah, so I've been in the NHS a long time, and like many people on the call, would consider myself to be a relatively hard worker. So, I don't put boundaries around my personal life, my work life, probably in the way that you should. And that's something that I think, always work on. I think that's because I thoroughly enjoy what I do and have a clear sense of reward. So, I would be the first to admit that, probably from early March last year, the days got longer. And sometimes did get quite difficult to handle, actually. The pressures were intense, and actually felt relentless. It felt like you just overcome one set of challenges and a new one would surface. And what was interesting was there were a few things that I soon recognised that I really missed. So I really missed my colleagues. And it wasn't the formal meetings I really missed, but I really missed the coffee conversation. The just bumping into somebody in the coffee room, or, passing somebody's door and just poking your head through and saying, "Hi, how you doing?" I missed having my hair done really badly. Missed having my hair done. I know that's a third world problem, but for me that was kind of a bit of a struggle. And it was hard, really, because in amongst all of that, I've just kind of said it. It was very obvious that my suffering was not representative in any way, shape, or form of the people we serve, and that the suffering that we were observing was disproportionately affecting people that it shouldn't have been affecting. And I think that's still something that morally and societally we've got to address. So we have to address some of the disparities. You know, Michael Marmot was talking this morning about how the pandemic has affected the poorest and those from other ethnic groups. And I think, you know, for me, almost dealing with some of that alongside, you know, the day-to-day pressures that you're dealing with, it takes you into a whole new place where you're kind of in touch with big responsibility, huge responsibility, actually. And so what did I do? I reinstated the coffee conversation by hassling my exec colleagues on Teams and chatting with them, not about anything in particular, but I would make a point of kind of putting touch bases in with people. I, like many people, actually, I mean, I've always exercised, but I kind of reconnected with the permission to go out for an hour a day and really did kind of get into walking in a way that perhaps I've not done before. You know, I've always gone out either to run but it was, I think, really therapeutic just to walk away from the desk for an hour and not think about what was happening back at the ranch. And I think actually, you know, I think one of the things that I'm really grateful for is, you know, I have a nice space where, you know, I can go out into the fresh air. But I did worry and think about those single mums who were in those high-rise blocks with their 3 children, and just think how impossible it must be in those circumstances and how difficult it must be for people to feel penned up in those circumstances. And you know, I still think we owe a huge, huge gratitude of thanks to people who must have put up with some fairly horrendous circumstances during those lockdowns. So, you know, I think there are things we need to do as senior leaders, you know, deal with the here and now, but also deal with the burden of responsibility that we all carry to move forward, trying to address some of these inequalities in everything we do. We have huge responsibility as anchor institutions to ensure that we are addressing some of this. And certainly for us at the North West Ambulance Service, I think if there's one thing that's come out of the pandemic, it is the determination to address some of these structural inequalities, both within our organisation, but also across the healthcare system in partnership with the integrated care systems as they emerge and strengthen.
Yeah, I couldn't agree with you more. I think it, you know, trying to understand that more is essential. I think the other thing is that seeing beyond the mask. So, you know, the fact that the people you describe can be the people who are working in your organisation. So, you know, the people who are struggling, who may have lost a loved one, who may have not had time to do all the things that we all love to do. You know, the numerous stories about people in their PPE and not wanting to eat or drink, because if you eat or drink, you need to do something else, and you know, and adjust all that stuff. And thank you, that was really beautiful. But so if we get back to the sort of the what is the system telling us about what's going on, about individuals, but also about the functionality and all those things. I remember when we were talking together before this, that you were talking about learning systems and how you're starting to think about setting up new learning systems. Maxine, you alluded to the fact that you need to learn about stuff in real time. So come to you, Sam, in terms of what learning systems that you think that you've evolved into that you feel you'd like to keep.
Yeah, so when the pandemic sort of hit us, we were about 4 weeks in, and I could see that we were learning loads. We were taking decisions, working in such a different way, but it was quite absorbing for the organisation. So one of the very early decisions we took, just to sort of briefly tell a story, is one of the last sort of trips I did in March was up to Birmingham. I went to talk at a women leadership event, and I stayed with a friend of mine while I was up there. And this was about 3 weeks before the major incident was declared, when it was just starting to look that, gosh, this could be really quite serious. It's sort of starting to sense this, it's coming. But we were just carrying on, you know, in the organisation. Down on our patch, we'd had a very early glimpse because we had the very first outbreak in Brighton. So we'd learnt a bit from that, which was helpful. But this friend I stayed with works in a global bank. And I had dinner with her that night, and she started to tell me everything the bank was doing. Being a global business, they were obviously operating in parts of the world where this was already hitting. And she said, you know, I'm already in my bubble. We're home working from tomorrow. And I'm suddenly thinking, oh my goodness, we've not made any adjustments to our organisation. I remember the journey back from Birmingham. And the first thing I thought on the way back was, oh my goodness, what if our payroll department goes down and we can't pay our staff? That's going to be really difficult. People don't get paid. And literally the following morning, we sent our payroll department home. They all went home. They put in place immediate remote working. And we actually stood up our Gold Command in the organisation 2 weeks before the national major incident was declared, because we were sensing this was coming. I'd had the benefit of that conversation, actually, from somebody in another sector. So we were starting to talk. And one of the decisions we made really early on was that I wasn't going to take the Gold Command in our organisation, because we thought this was going to be a long incident. And so we set up a rota of 3 of the executive team. And that stood us in good stead. They took a week at a time as Gold Command. And so sort of 4 weeks in, because I was able to have more of a helicopter view, work with the system, the integrated care system, with my other chief executive peers, I could see we were learning a lot. But a lot of my team, a lot of people in the organisation were focused on responding to the incident. So what I decided to do was, it was a bit radical, but decided that we would set up a learning project. I asked my director of R&D, and I gave him a really simple brief, which was, don't write me a dissertation. I want a slide deck in 30 days. What are we learning? Here's a team of people to work with. None of them are involved in the immediate response to the Gold Command and the incident. You can go anywhere you want in the organisation. You can do this any way you want. And that started our Learning from COVID project. I think Simon's going to just put the slides up. This is all available on our public website. We're now into the 3rd phase of that. So we've gathered evidence all the way through. We looked at 6 areas: video conferencing for service users, for teams, how we were adapting our crisis pathways, working from home, rapidity of decision making, and staff wellbeing. And the latest report will be out shortly, where we've looked at the patient experience of digital. We've now done 90,000 digital consultations since the pandemic started. So we wanted to make sure we were capturing this evidence as we went, and we're going to continue with this Learning from COVID project. And we've got the evidence, Suzette, so we've been able to make some adaptations to the way we've been responding as we've gone.
Lovely. Sorry, I was just trying to see whether your slides could be popped up just so that you could show people, but that we'll move on from that. If we want to, we can come back to them. So thank you. I think totally inspired, and isn't it funny? Chance conversation can also be a crucial piece of data. I went on holiday just before the pandemic, and my piece of data was at the airport and the place where we were at, multiple people wearing masks, and I'm thinking, who are these people? And this little piece of information kept lodging into something's going on, and it's those things that if you can get as much advanced information as you possibly can. I know that's tricky, but forearmed and forewarned and all that resilience engineering stuff that people talk about. So Maxine, what about you and your learning processes and systems? Have they changed, evolved, or what have you been doing with them?
Yeah, so just before I do that, I mean, what you've just said, Suzette, and what Sam said, is, I think, exactly what we're describing here is the epitome of sense making, isn't it? Problem sensing. And yet it's interesting because it's almost like culturally there are a set of beliefs that conspire against us to make it not difficult but trickier to do some of that. So, for example, I think I mentioned to you when we were talking, our hazardous area response team has all of our essentially enhanced training around dealing with pandemic flu. So they have the hazmat suits, they have the breathing apparatus, etc., etc. And of course, you know, in the past 3 to 4 years, they've dealt with a number of kind of early warnings around a flu pandemic, all of which have been contained, and all of which have then subsequently not really reached the mainstream service. So it's almost like, on one sense, you've got these extreme signals coming up through the system, and yet you've got a whole host of people whose lived experience is that this is going to come to nothing. So why are we bothering? So it's almost like problem sensing doesn't exist in a vacuum. It's almost like we're constantly, you know, people are constantly acting to put a fire blanket onto problem sensing and make it seem irrational. So I think it's a really fascinating, you know, problem sensing in situ is quite a hard thing to I think, you know, trust in a way. Well, for me, for sure. So you asked about learning, didn't you? That was my question, but I couldn't resist coming back on that, because I just thought, you know, we were, I think, caught on the back foot. We didn't expect the scale of transmission that we saw, I think, because we have had, as I said, a number of contained global pandemics before this one. We had done some simulation work, haven't we, as a nation, on what would happen. We knew that there were some gaps in that. We haven't necessarily addressed those gaps fully. So, you know, I think there are a few lessons for us to learn there. The thing about learning systems, so learning systems have been a fascination to me for, you know, all of my career, really. I mean, essentially, if you think about the roots of improvement, that is about embedding a learning system into either a team or a department or an organisation or an entire system, which thinks differently about taking something, you know, that's relatively small in size and then iteratively testing it quickly to enable you to fail and learn. And I think this is where, you know, so for us, there were a number of examples where I was quite encouraged, actually, because I had people coming to me who I think 3 years previously perhaps hadn't have come to me with the kinds of suggestions they were making. So they were saying, we don't know how to do this, so let's test this particular approach. We'll come back together, we'll discuss how it's worked in practice, and then we'll refine our ideas and we'll grow it. And we tested our way and we learned our way to the implementation of testing for all of our staff, you know, COVID-19 testing, which we extended to their families. We tested our way into how do we get our staff all to use daily testing or lateral flow testing. We tested our way into getting them antibody testing. We tested our way into getting them vaccinated, because we didn't know how to do any of that, really. We'd done some of it. We've done winter flu, you know, we've done winter flu jabs, but actually not at pace and not at the scale that we were trying to introduce all of these measures. And we knew, actually, that really the only way to manage this was with agility. So I would say that what this did for us was it didn't necessarily introduce something new, but it gave people confidence that they could do this and that they would be supported, and that they would be supported to find a solution rather than think up a solution, which is very different from, you know, where I think we might have been 5 or 10 years ago. I think for the board and senior execs, there is a nervousness, as Sam said, you know, when this is about something that's absolutely mission critical, like getting all of our staff access to COVID-19 testing, and we've got 1,000 people self-isolating. You know, they're like, really, Maxine, you want to do one test to change, you know, and then another and another and another? Can't we just implement? Well, no, actually we can't. And if we do, when we choose to move to implementation, we will still be learning. And so, you know, I think there is something about holding your nerve, but I think what we've got now is a real opportunity for a different way of working, a way of working that is much more akin to a learning system, are much more comfortable with the fact that when we learn predominantly from failure in order to get to success.
Fabulous, thank you. We sadly haven't got that much longer together, and it's been so lovely to chat to you both. And I'm trying to pick out what I think might be the most brilliant last conversation, and I suppose it brings back to something both of you have said, is in relation to, we're only here for our patients and their families, and then supporting our staff to enable them to do that. And problem sensing isn't just about hearing about, as we've said, the data of the system. It is about hearing from them. So one final question for you both, and I'll give you like 2 minutes each, which is, how have you, or how do you intend to draw the voices from patients and their families and your and the service users in your organisations? So I'll come to you, Sam, first.
Yeah, so we've got quite substantial sort of people participation part of the organisation, and we have a growing and expanding peer support workforce through our mental health and learning disability services and autism services as well. And our working together groups, and in fact we had their first conference this week. It was online, fantastic. They told their story over the past years. Not only did they continue to adapt during the year, they went online, they set up weekly groups, they worked on specific projects to support service delivery, and anybody's welcome to those groups, people, not just people in paid employment in the organisation, patients, and we also did similar with our carers as well. So one of the things we found early on is that they also had to adapt our recovery college. So instead of being face-to-face, that's all online and digital now. And they really developed some great digital skills. And they actually have run training sessions for other colleagues across the organisation in, for example, how to use Zoom, WebEx. We've got a plethora now of platforms, as I'm sure everybody has. So they've really been at the heart of that. I don't think, though, I think there's a lot of voices we're still missing that I'm curious about. And I think we're seeing through the recovery and restoration process, people come into services who've been isolated, that there's a lot more that we need to do to really understand the true impact of people over the past year, and really make sure that we really learn from this in terms of how we need to adapt services for the future. And indeed, there will be some stories that we missed, and sadly and tragically over the past year, some service users we've lost during this process. And through the learning systems we've got in place around incident reviews, really making sure that we do take all the lessons of that. And I think particularly for us, one area we're really focusing on is our community services. And over the past year, how they had to adapt their offer, and actually what the lived experience of that has been for patients and families. And it's needless to say, there have been some really good bits of that, and there's been some really challenging, difficult bits to that.
Yeah, absolutely. Maxine?
Yeah, so I think we're all still learning how to do this. I do believe that there are sectors like the one that Sam works in where they are way ahead of the game. And I listen with envy to what Sam has just described. So whatever I offer is going to be a meagre representation. But what I would say, I think in terms of partnering, there's never been a time for me when people have wanted more to partner with us as NHS providers than now. I think we have we should be proud and also a little bit scared of the social capital that the NHS is carrying right now. It's a privilege, but also it's a responsibility that we carry. So we have listened more. We've had more. We haven't in any way paused our engagement. In fact, if anything, we've accelerated our plans to engage with our service users. I think, though, that there's one thing for me that feels really important, and that is the kind of embedding whatever work you do in storytelling. and in listening to people's lived experiences. And often what you find when you talk to people about their lived experience, it isn't necessarily about one service provider, it's about the integration or the disintegration of services at the point of the person, the individual, the family. And I think it's really important that we, all of us, listen to that. I certainly, encourage all of my teams to start every meeting we have with a story, either in person from a patient or a second person narrative about why we're here. And I know that some boards do this, but I think actually sometimes it works really well, but sometimes it's quite stale. And I think we need to refresh that and think about how we can do that creatively and differently, and continue to really, really listen to those stories. And I think one of the things I would say is that obviously, we also within NWAS, we've worked with 1,500 community volunteers during this pandemic. They turn their pages on at night when they finish work to respond to cardiac arrests. Community first responders, they come in on their days off to pack PPE. They talk to us about their experiences of using our services. And they are truly, truly remarkable people. So for me, the one thing I would carry forward into the pandemic is still to remain a student of co-production, because you never ever stop learning.
That's a wonderful ending. So thank you so much to Maxine, to Sam, for a thoroughly enjoyable conversation I could have had and gone on for hours and hours. What we've learned is how two very special people have learned to adapt even further than they've learned before, to question everything around them, the data, the storytelling, their own feelings, and that of their staff, and to truly, really, really listen as much as they possibly can. They've also understood that the things that they might have thought in the past might be different now. So even our theories and our ideologies, and we think that we're hard and fast in terms of this is what I believe. And actually that shifts a little bit when we get confronted with something that we've never actually been confronted with before. And what we've seen is two people who have embodied for me that whole wonderful thing of kindness. And I talk about that a lot, and I make no apologies whatsoever by talking about it, because it's a very, very strong character trait. And I think that throughout the last year, if nothing else, we needed to be kind to each other. But I'm going to finish with the thought that Maxine and Sam need to be kind to themselves and think very, very long and hard about how can we maintain what we're doing, and not struggle and suffer in any way. And I know that everyone who's listening and watching will be in that space. And that's what we all need to hold on to, is to hold each other gently, even when we're allowed to, which we're kind of now, but do that with a massive amount of empathy and support. So huge respect, Maxine and Sam, thank you. Thank you for the conversation. Thank you to everyone who's been listening, and enjoy the rest of your day.